Hello, my name is Konstantinos Linos, and I'm a dermatopathologist and bone and soft tissue pathologist at Memorial Sloan Kettering Cancer Center in New York City. The topic that I will be presenting today is on keratinocytic / epidermal tumors, based on the new WHO classification of skin tumors, the 5th edition that was published this year in 2023, at least online. I'll turn off my camera so you can concentrate on the slides, and I will reappear at the end of the talk. And feel free to post any questions you have at YouTube, and I will try to do my best to answer them. All right. Let's start. So the first category is about premalignant keratosis and precursors, which includes actinic keratosis, arsenical keratosis, pulvokeratosis, and squamous cell carcinoma in situ. We'll start with actinic keratosis, which are very common neoplastic intraepidermal squamous proliferative lesions that they are associated with UV exposure, ultraviolet light exposure, and are characterized by squamous dysplasia, as you can see here at the basal keratinocytes. By definition, they don't have a full thickness atypia, which will be equivalent to squamous cell carcinoma in situ, so they don't affect the full thickness, but they can expand. They can go down the adnexal structures, down the acrosyringeal units, and the follicular and the follicles, but the as we're going to say, the parakeratosis is spurred on the on top of the acrosyringeal units and the follicular ostia. Now, actinic keratosis are stable. Most of the times they can regress spontaneously, or sometimes they can progress to invasive squamous cell carcinoma. The granular layer is typically absent, and there is, as you see here, overlying parakeratosis. But however, as I said, the parakeratosis spares the acrosyringeal units and the follicular ostia. However, the dysplastic keratinocytes can extend along the pre-existing adnexal structures. And as I said, by definition, full thickness atypia is lacking. And for the most times, there's a sand damage background of sand damage skin. There are various types of actinic keratosis. The hypertrophic actinic keratosis is characterized by this verrucoid epidermal hyperplasia with this massive overlying parakeratosis, but again, the acrosyringeum is spared and the follicular ostia is spared, so there's alternation. There is the proliferative AK, where we have prominent buds of dysplastic epidermis protruding into the superficial dermis. Acantholytic actinic keratosis, when you have acantholysis at the atypical basal keratinocytes, that they can actually extend down the follicular structures. And pigmented actinic keratosis, where you have pigmentation in the atypical keratinocytes, and you can have melanophages in the superficial papillary dermis, and this can resemble a melanocytic tumor clinically, and sometimes have to be careful because it can resemble a melanocytic tumor histologically as well, and specifically you have to exclude, rule in or rule out melanoma in situ lenticule malignant type. In terms of prognosis and prediction, as I said, many remain stable, or they can even regress, and some they will progress to squamous cell carcinoma in situ or invasive. 65% of the primary cutaneous squamous cell carcinoma, they will arise in the background of AK. We see that all the time. And the risk of progression is quite low, is about 0.6% after a year. 2.57% after 4 years, and about 7 out of 10 keratosis that will have regressed after 5 years. Now, arsenical keratosis, they present as this hyperkeratotic lesions, and they have a predilection for hands and feet, and this happens after a chronic exposure to arsenic. Now, the incidence in developed countries, including Greece, is very low. However, the disease is predominantly seen in poorer nations due to contamination of the groundwater. There is a spectrum, a morphologic spectrum of arsenical keratosis, where it ranges from just acanthosis with papillomatosis and hyperkeratosis to areas with squamous dysplasia, and the cells have often vacuolated cytology of the dysplastic keratinocytes, and the squamous dysplasia does not affect, if you see squamous dysplasia, does not affect the full thickness epidermis. The arsenical keratosis continue to grow over time and may or may not progress to squamous cell carcinoma in situ or even invasive. Pulvokeratosis there are hyperkeratotic cutaneous lesions that they develop on sun-protected skin, and this happens after prolonged PUVA treatment, shoreline and ultraviolet A treatment for different diseases, for example, psoriasis, and the effect is dose dependent. The pulvokeratosis, there are multiple warty hyperkeratotic scaly papules, as you can see here, and the histologic appearance is that of a disorder of maturation. They have this diminished granular cell layer. There's an abrupt change between normal and abnormal epithelium. They are very well demarcated and they have acanthosis and overlying hyperkeratosis. A papillomatous growth or parakeratosis may be present, and mild keratinocytic dysplasia, as you can see here, can seen in about half of the biopsies. And of course, you may or may not see some superficial dermal chronic inflammatory infiltrate. Molecular analysis of pulvokeratosis show that they have p53 mutations or HRAS mutations, which is a UV signature point that the ultraviolet exposure is the main etiological factor in these lesions. There is increased risk of development a non-melanoma skin cancer in these tumors, particularly squamous cell carcinoma, and less often basal cell carcinomas after years of prolonged PUVA treatment in patients with pulvokeratosis. And as I said, this is dose dependent. Squamous cell carcinoma in situ or Bowen's disease is confined by definition to the epidermis and the superficial adnexal epithelium, and is characterized in contrast to actinic keratosis by full thickness involvement of the epidermis by dysplastic squamous cells. So histologically, you see these red scaly pads, and in specific anatomic locations, for example, genital, vulva, you will use vulva intraepithelial neoplasia, grade 3, or penile intraepithelial neoplasia, or perianal intraepithelial neoplasia, rather than squamous cell carcinoma in situ, but there are synonyms. Approximately 3 to 5% of squamous cell carcinoma in situ will progress to invasive squamous cell carcinoma. Pathogenesis is UV radiation exposure, either UVA or UVB, either because we stay too much outside in the sun, or unfortunately from tanning beds. Radiotherapy and photochemotherapy can increase the risk and cause squamous cell carcinoma in situ. High-risk HPV infection in perianal region or genital skin are causative factors. And the beta genus HPV have synergistic effects with UV radiation in the setting of immunosuppression, for example, HIV patients or organ transplants. And if you get SCC inside to young individuals, especially non-sun damaged skin, think about arsenic exposure. Now, your classic differential squamous cell carcinoma in situ is between mammary or extramammary Paget's disease, and of course, you can think about melanoma in situ, reticular cytosis, etc. Traditionally, for differentiating between mammary and extramammary Paget's disease, people use CK7 and COMT5L2. But I would say that there's evidence suggests that there are good markers, but P63 has a very high sensitivity and specificity. This is a case of squamous cell carcinoma in situ that a differential of Paget's disease was raised because this happened to be CK7 positive and some COMT5.2 positivity, which can happen, but it was diffusely and strongly positive for P63. So the panel P63, CK7, COMT5.2, this is the classic SSCIS, which you expect to be negative. The classic Paget's disease or extramammary Paget's disease are positive for CK7 and positive for COMT5.2, negative for P63. The staining you see here is the basal keratinocytes, but if you go high power, you actually see the neoplastic cells are negative. But then they don't always follow the book. This is a squamous cell carcinoma in situ that had some positivity for CK7, which can happen, seen many times, or low molecular weight keratin. So you P63 is the way to go. It extends the P63 diffusely and strongly positive, where on the contrary, this was an extramammary Paget's disease that happens to be negative for CK7, has some positivity for low molecular weight, but it was negative for P63. This is again, this are the so you should go high power. These are the basal keratinocytes and not the actual tumor cells. One thing I want to mention is sometimes we see classic subcase, but subcase have different subtypes, and there's a subtype which is a clonal subcase, like the one we see here. Clonal subcase without atypia, we see all the time. But sometimes it's really, really difficult, struggle. You don't know if it's actually, they look atypical, you don't know if it's actually a saddle bounce disease or chronic subcase with atypia that exists. So people have looked at this and they found that clonal subcase are actually more likely to recur than non-clonal subcase. And actually, clonal, if it's going to be the upgrade rate of squamous cell carcinoma, at least in situ, it's going to be with lesions with clonal subcase. So the clonal subcase are more likely to recur, and if they recur as squamous cell carcinoma in situ, most likely that was a clonal subcase with atypia rather than without atypia. So it matters. So pathology should report the presence of clonal pattern in observed separate keratosis, indicate if there is atypia or not atypia, and provide lesional margin assessment. So the essential criteria for squamous cell carcinoma in situ is the replacement of full thickness of epidermis by atypical keratinocytes with absence of maturation and frequent dyskeratotic keratinocytes. The cells may or may not have a pasitoid appearance, and desirable but not essential. You may have loss of granular cell layer of epidermis, mitotic figures visible above the spinous layer. Let's talk a little bit about verruca vulgaris, verruca plantaris, verruca plana. This is a classic verruca vulgaris. It's a common HPV-induced benign cutaneous squamoperipherative lesion. You have this hyperkeratosis, papillomatosis, and kind of inwards proliferation of the rete regis. You go higher magnification, you have this hypergranulosis and colocytes when you have this coarse keratohyalin granules, and then columns of parakeratosis, and in the epidermis you have dilated tortuous capillaries that occupy the papillary dermis. You may see a lichenoid inflammatory infiltrate, sometimes Spurgeon, and may correlate with the regression. And there is a differential, of course. One differential is verrucous psoriasis, which you'll see papillomatosis, acanthosis, parakeratosis, and thinning of the granular layer. And you're going to see trachonian neutrophils and microabscess and dermal vascular dilatation. And of course, clinical correlation is essential. Multiple epidermolytic acanthomas that can mimic verruca vulgaris. That would be, I guess, your differential. And then you can see verrucas in the palms and soles, verruca plantaris and palmaris, that they are partly endophytic, have this papillomatous epidermal lesion, that have this coarse intracytoplasmic inclusion-like keratohyalin granules that are present with the superficial keratinocytes. And we don't use the term myrmecia, but it kind of resembles myrmecia, so-called unhealed. And these lesions may regress. And when they're regressing, they're exhibiting hemorrhage, necrosis, thrombosis, and a mixed inflammatory infiltrate. And they can regress spontaneously. And actually, lesions in children, presumably because their immune system is so much stronger, they typically resolve more rapidly. Verruca plana is also an HPV-induced benign epidermal proliferation that is characterized by flat-topped cutaneous papules. The epidermis shows orthokeratosis, mild acanthosis, and hypergranulosis, as you see here, and then you have the central aggregate of colocytes. So if you have multiple plane warts, more than 5% of the body surface, this is a potential harbinger for underlying HIV infection. And in HIV-infected patients, a sudden eruption of lesions may herald the immune reconstitution of inflammatory symptoms. Now, they can actually also regress, and you have a superficial perivascular lymphocytic infiltrate with lymphocyte exocytosis and apoptosis. Epidermal dysplasia verruciformis is usually associated with HPV 5 or 8 and exhibits a spectrum of features, including orthokeratosis and an irregular granular layer. And you have these enlarged keratinocytes with abundant bluish gray, often vacuolated cytoplasm. Moving on to benign acanthomas and keratosis. This is your classic seborrheic keratosis. It's a well-circumscribed papillomatous architecture and a flat base. There are different subtypes of seborrheic keratosis: acanthotic, adenoid or reticulated, clonal, irritated, pigment, and staphylokeratosis. From these, I would say the most important is the clonal type for reasons that I showed in the previous slide. Now, paradoxically, there are oncogenic mutations, including very frequently FGFR3 mutations, which have as a result the increased keratinocytic proliferation and reduced apoptosis. There are other mutated genes like KRAS and HRAS, PI3K3CA, etc. So now why these mutations, they fail to lead to malignancy, and rather they lead to a very stable benign neoplasm. It's quite unknown, and HPV DNA has been seen in about half of seborrheic keratosis and the genital lesions. And sometimes it's extremely difficult to see, is a verruca, is a seborrheic keratosis. You struggle every day. Sometimes you can't tell. So the term verrucous keratosis, verrucoid keratosis, it's actually appropriate in its time. Psoriasis lendico is another UV-related benign intraepidermal keratinocyte proliferation, which is closely related to seborrheic keratosis. Many times you see that in association with seborrheic keratosis, and you have this basal layer hyperpigmentation with accentuated at the tips of the radial ridges, the so-called dirty fingers, in a solar background. They also show FGFR3 and PIK3CA mutations. So the occurrence of these mutations in both seborrheic keratosis and PI and solar indigo, they show their common genetic basis, and it's possible, very likely, that solar indigo is just a baby seborrheic keratosis. The findings further substantiate the fact that UV exposure is a causative factor of these lesions. But of course, every time you diagnose solar indigo, you want to make sure that you don't miss a very subtle melanoma in situ, lindico maligna, and if you have doubts, you can stain it, and you can see the confluence of melanocytes and positoid epic migration in these lesions, but sometimes can be very subtle. Prey can be very useful, but sometimes can be very sharp. You don't have to stay in every solar lindico, obviously. Most of the time you can say, you can figure it out by morphology, but sometimes you need to use some stains. Lichen planus-like keratosis, another benign intraepidermal keratinocytic neoplasm that has some reminiscence to seborrheic keratosis, and most likely is an actively regressing seborrheic keratosis, but in addition has this superficial dermal chronic inflammatory infiltrates with interface changes, which they are regressive changes. And people have looked at this, and they show that lichen planus-like keratosis, they have FGFR3, PIK3CA, and RAS mutations, and people have looked the normal, adjacent normal epidermis and the inflammatory infiltrate, and don't have the mutations, but actually the actual lesion, the epidermal lesion, has the mutations, which shows that they are related with solar indigo and seborrheic keratosis, and probably is a seborrheic keratosis actively regressing. And if you are wondering, people have looked at the lichen planus cases, and they are wild type, they don't have these mutations. And of course, you need clinical, you need to, because there is such overlap histologically, the solitary lesions with lichen planus have multiple lesions. You really, if the solitary lesion, but if you don't have that lesion, it's very difficult sometimes to say, is it a lichen planus-like keratosis? Is it lichen planus? Is it a lichenoid drug reactions, etc.? So clinical is very key in this scenario. And of course, these lesions have a life, as Ackerman was saying, and you can see they can actively regressing, and then you can see something that is at the end of the spectrum, which is almost gone from the course of the regression. But of course, every time you diagnose a lichen planus-like keratosis, you want to make sure you're not missing an actively regressing melanoma. In this case, it's a very inflamed, actively regressing melanoma, highlighted by SOX10, with this confluence of typical melanocytes going down to the adnexal structures. But the opposite can happen. You can actually react and overdiagnose this. This is a case that sometimes can be seen in lichen keratosis, where they have this pseudomelanocyticness. And of course, this is a case, and they're true melanocytes, they stand for MITF, they stand for SOX10. It's just probably reorganization of the junctional melanocytes. Of course, clinical is key here. This was a case, the clinical was either post-inflammatory hyperpigmentation or melasma. So this is unlikely to be melanoma. But of course, it could be just a solitary lesion that you can have this pseudomelanocyticness. So you have to be careful, but the melanocytes, they look pretty bland, they're not confluent, you don't have positoid epic migration. This was a patient who had a stem cell transplant. So he had graft versus host disease with interface changes along the dermal junction, and reorganization of melanocytes would have a pseudomelanocyticness, which were positive for MITF and SOX10, but again, they were looking pretty bland. They were not like very, very broad. They didn't have positoid epic migration. So you have to be careful. And of course, in this particular scenario, the clinical doesn't fit. It's not melanoma. People have looked, if frame the stain can be helpful in these cases. The brand that we use it every day in our clinical practice has, of course, has its limitation, is not perfect in terms of sensitivity and specificity, but can be helpful, and I find it very helpful in lendico malignans, which is many times is positive, but again, it's not 100% positive. But in lichen keratosis with pseudomelanocytic nest, we expect to be positive in melanoma in situ. Many of them, not all of them, though, will be positive. But again, I stress we can't rely just on one marker. The correlation of morphologic findings, cytologic atypia, pachytoid scatter, confluence of atypical melanocytes at the dermal junction with the clinical picture is essential. Is it a rash? Is it just a sordide lesion? But it's another tool that can help us make more accurate diagnosis. Clear cell acanthoma is a sharply demarcated intraepidermal keratinocytic proliferation, has this pale to clear staining of cytoplasm, and has this psoriasiform epidermal hyperplasia, and people have actually questioned if this indeed is a neoplastic process or not, because this is still debatable, because the solitary nature and the persistence and the lack of regression point to a neoplastic origin. However, people have looked at this, and immunohistochemically has demonstrated similarities with keratin expression with psoriasis, and it's different from those of the normal epidermis. Sometimes it's the same, sometimes it's not, but it's known that the expression of keratins is in psoriatic epidermis is changing. It's not exactly like normal epidermis, so this abnormal differentiation of keratins can be seen in psoriasis, and clear cell acanthoma has shown a similar pattern to inflammatory dermatosis, psoriasis, lichen planus, discoid lupus erythematosus, etc. So this may actually be a localized form of inflammatory dermatosis rather than a neoplasm, but again, the debate is still open. The pale keratinocytes are PAS positive, they're glycogen, and then you can see overlying parakeratosis as well with intraepidermal, intracorneal neutrophils, which is a clue for this diagnosis, or you can argue that this is more of the psoriasis. Large cell acanthoma is another benign intraepidermal keratinocytic proliferation, as it's the morphologic spectrum of solar lendico and early seborrheic keratosis. There's significant overlap. There is a sharp delineation from the adjacent normal epidermis. Cases that look kind of, they don't look atypical, but they look enlarged with the smooth nuclear contours. And their cases often admixed with solar lendico. Actinic keratosis, obviously, quite frankly, I call this solar lendico. I rarely use this term. I think there's significant inter-observer variability in this stuff. But actinic keratosis will have more squamous dysplasia at the lower basal keratinocytes, and lendico maligna, which could be the differential, will have obviously atypical melanocytes, even if it can be subtle, and if it's subtle, you can sustain with a soft stent. I discourage you to use Melan-A because people overcall all the time because it stains the dendritic cytoplasm, so it's better to use Soxtan. And of course, it will be a confluence of atypical melanocytes, etc. Wardig dyskeratoma is a benign endophytic squamoproliferative lesion that arises in association with pilosebaceous units, and it has this acantholytic dyskeratosis. You'll see this dyskeratotic keratinocytes, and the differential diagnosis here will include diarrheal disease and Probert disease, but of course, the clinical scenario will be completely different. So that will be easy to dismiss, and then acantholytic squamous cell carcinoma will show all this keratinocytic atypia, not just splastic keratinocytes, but true atypia. And if it's invasive, you have, of course, it will not be that well demarcated and have an infiltrative growth pattern. Now, Wardig dyskeratomas can be seen in association with BRAF inhibition, the same thing you see with KI. So MAPK activation plays a role in their formation, and you can also see multiple warty dyskeratomas, which is rare, not in a different scenario apart from the BRAF inhibition, that has been reported in the setting of renal dysfunction. Other benign keratosis that don't quite fit in other is acantholytic acanthoma, acantholytic dyskeratotic acanthoma, epidermolytic acanthoma, granular parakeratotic acanthoma, psoriasiform keratosis, and melanoacanthoma. We like names, I guess. Acantholytic acanthoma, this is well circumscribed keratosis, usually have this epidermal acanthosis, and you see this acantholytic pattern kind of resemble pemphigus vulgaris or pemphigus foliaceus or Hailey disease. But of course, the clinical scenario will be very different. You don't usually see dyskeratosis, or you may see acantholytic dyskeratotic acanthoma is a solitary lesion, as dyskeratosis and acantholysis, as the name implies. Epidermolytic acanthoma, again, is a solitary lesion, has this striking pattern, bulbous pattern of epidermolytic hyperkeratosis. Granular parakeratotic acanthoma resembles the adenoid pattern of seborrheic keratosis, but has marked granular parakeratosis. Psoriasiform acanthosis kind of looks like psoriasis, you have parakeratosis, you may even have intracorneal neutrophils, but it's a solitary lesion. And melanoacanthoma looks like seborrheic keratosis, but it has numerous dendritic melanocytes, but they are very bland, and many pigmented keratinocytes. And you see melanae or substain, you see increased melanocytes, but they don't look atypical. But of course, you can have colonization of seborrheic keratosis by melanocytes. You got to be a little bit careful, but you have to be careful in this scenario not to overcall melanoacanthomas or something more atypical. All these tumors, they kind of resemble various dermatoses, which have the same patterns. So, and they can actually look exactly the same histologically. So I can't emphasize enough the significance of the clinical presentation. Either solitary papules, or the rash, or the plaques, that will give you the right diagnosis. Melanoacanthoma, again, you have to be careful not to overcall increased melanocytes. Again, you can be praying, you can see if there is a change in melanocyte or not. So you have to be a little bit careful. And sometimes, as I said, you can't tell if it's verruca vulgaris or seborrheic keratosis. You use just the term verrucous keratosis, and you're done. Let's move now to basal cell carcinoma. Basal cell carcinoma arises from epithelial cells of either the epidermis or the Hell follicle stem. There are various morphologic types that have the distinctive clinical and physiologic findings, but they have similar epidemiology and etiology. Very commonly, they occur in the head and neck because of the UV radiation, but it can be encountered in non-UV exposure areas, so that doesn't exclude it. If it looks basal cell carcinoma, that's what it is, but you have to have your criteria straightened up. So there are basal cell carcinomas in the perianal region, in the genital region, in the nail unit, and or in the soul. And ultraviolet radiation exposure is, of course, one reason. The radiation treatment is strongly associated with chronic arsenic exposure. Now, they can be seen with various genodermatosis. One of the most common is the Gordon syndrome that have mutations in the PTCH, SMO, or SUFU. And these patients also get odontogenic keratosis, the plantar pits, scalp abnormality, etc. So basal cell carcinoma is one of the most frequent cancer in the human body, and it has the most mutations comparing to any other human cancer. And there is an interplay between genetic susceptibility and sporadic UV-induced radiations. Germline mutations in PTCH1 are seen in about 60 to 70%, seen in Gorlin syndrome, and a loss of heterozygosity of PTCH is seen in about 60 to 70% of sporadic PCC. So what happens is usually the PTCH has a controls the SMO, transmembrane SMO protein, kind of has this negative effect. And when you have this ligands to the PTCH, then this negative effect stops, and then you have positive enforcement of the CMO, that it goes and has an increased release of activation of the GLI1, that then they go to nucleus, and you have activation of the relevant genes. Now, when you have a mutation in PTCH1, that means that inhibition stops and you have activation of the GLI1, etc. Or if you don't have mutations in PTCH1, you can have less frequently mutation directly to smoothen the SMO or the PTCH2 by UV signature. And when you have a mutation SMO, the drugs that we have for advanced basal cell carcinoma, like vismodegib or sonidegib, they don't work. So this is the molecular pathogenesis of basal cell carcinoma. And that is very important, because if you have a metastatic basal cell sarcoma, that's where you need the drugs, and you need to know if it's actually basal cell carcinoma, because sometimes they change morphology. This was a classic basal cell carcinoma that behave very aggressively and metastasize to the lung, and the lung you often only see very focal, this basaloid phenotype, and most of the time have squamous differentiation. So if you didn't have any history, it would be very difficult, but these tumors will be PTCH1 or PTCH2 or small mutated, and it can be very important to diagnose, very important to for diagnostic purposes. Either you have or you don't have a history of basal cell carcinoma, like the second squamous cell carcinoma, for example. So, and it's very important for treatment purposes, because if it's PTCH1 mutated, the drugs presumably will have a chance to work. But if it's SMOFN mutated, they probably have a resistance. And there are good evidence that we use head-scope inhibitors. They offer to patients with locally advanced or metastatic basal cell carcinoma, and there's evidence-based recommendation that immunotherapy can work as a second-line treatment in patients who progress or have contraindications to head-scope inhibitors. There are various subtypes: superficial basal cell carcinoma. The term superficial multifocal or superficial multicentric is not recommended anymore. They present as erythematous patch, often with rolled borders with multifocal erosion. This is the dermoscopic feature, have this pigmentation and micro ulcerations and these white lines. And by histology, they have this basaloid epithelium emanating from the dermal junction, and they have this chronically inflamed kind of fibrotic appearing dermis. So if you see that pattern of the dermis extending the margins, the margins are not clear. Maybe a basaloid epithelium a little bit further down. They have very low risk for recurrence and have a negligible risk for metastasis. So essential or erythematous mildly scaly patches, dermoscopy, that's fine telangiectasia with small erosions and white structures, and these basaloid cells, lobes of basaloid cells with peripheral palisading extending from the base of the epidermis into the papillary dermis. Sometimes it's very difficult to say, is this a superficial basal cell carcinoma, or is this actinic keratosis? BR84 can be helpful differentiating between these two when it works. Doesn't work all the time, but when it works, it can be helpful. And then we have basaloid perforations that are not basal cell carcinoma. They can be seen overlying a scar, or they can be seen as follicular induction, for example, in dermatofibromas or other reactive or neoplastic conditions. And they can even have these clefting, this retraction clefting that you see in basal cell carcinoma. And this particular case, because this is the Merkel cell, and you expect that the basal cell carcinomas to be devoid of Merkel, CK20 Merkel cells, where reactive conditions to have a to be present, and then they don't have brisk mitotic figures, or they have necrosis or significant atypia. Nodular basal cell carcinoma is the most common basal cell carcinoma type. It's very well circumscribed. It has this large dermal tumor islands and peripheral palisading that can be pigmented or non-pigmented, and it has this telangiectatic vessels and this pearly look clinically. And you have, by dermoscopy, you get this white globules or brown globules with this serpentine vessels. And then nodular BCC can have different patterns. You can see prominent basement membrane here. But there are so many different types. I mean, I don't know. They have no clinical significance. We didn't. There are like more than 30 types: clear cell, granular cell, signal, you name it. There's even things, but most of them have no clinical significance. One thing you should be aware is that neuroendocrine differentiation doesn't mean Merkel cell carcinoma. Neuroendocrine differentiation is known to occur in basal cell carcinomas that can be positive for chromogram and synaptophysin. This can cause diagnostic difficulties. And CK20, of course, will not have the CK20 dot-like nuclear positivity you see in Merkel cell carcinoma, and Merkel cell carcinoma now having immunohistochemistry for polyoma virus. Just have to be careful that this can happen, that the histology is different. That is something that would be a dreadful misdiagnosis. Trichoblastoma, again, is a differential as well. It has this basaloid germinated follicular cells, but stroma doesn't have tumor to stroma clefting, has stroma to stroma clefting, and the cells don't look that atypical, and it has this mesenchymal bodies that you don't expect to see basal cell carcinoma. But sometimes it's difficult, so we have to use immunohistochemical stains. Of course, they're not perfect. Sometimes they confuse the situation rather than resolved. But if they follow the book, you would expect in the epithelial cells to in trichoblastoma to be CK positive, that we should highlight the Merkel cells to be CK20 positive, where the basal cell carcinoma will be devoid of Merkel cells. And then there is this follicular stem cell marker, the PHLTA, that has been proposed that can be helpful diagnosing between trichoblastoma and basal cell carcinoma. Usually it's positive in the former and negative in the latter. And the same thing goes with trichoepithelioma versus basal cell carcinoma. The trichoepithelioma would expect to be positive, while the basal cell carcinoma to be negative. The PHLDA will stain the intermingled melanocytes. As you see here, you can see very well because the tumor is positive, but you can see pretty well here in the basal cell carcinoma where the stain is actually the melanocytes. And the CK20, the Merkel, the basal cell carcinoma will be devoided. Well, trichoepithelioma will have, this one doesn't have a lot, but you can actually see staining with one. It's not perfect, but it can be helpful in difficult cases. And the other thing that would be the differential would be a trichogerminoma, which looks very, very uniform. This well delimited trichoblastic tumor that located in the epidermis or can extend to frequently to the subcutaneous tissue. This nodular architecture, sometimes we have this biphasic pattern. We have this nests and less and cells that they are configured in nests. If you do CK20, will highlight numerous Merkel cell carcinoma cells, and actually they have recurrent GRHL fusions, which is kind of exciting. And these were not seen in other entities in the progression, including basal cell carcinoma. So GRHL1 fusions may represent the oncogenic driver behind this subset of follicular tumors that is characterized by numerous Merkel cells and immature features. So essential and desirable diagnostic criteria: papule nodule ulceration and causally pigmentation clinically and well circumscribed variable size nodules of basaloid cells with peripheral palisade. Micronodular basal cell carcinoma, they present as a pink papule or nodule, which is often ulcerated, and it cannot be distinguished from nodular basal cell carcinoma on naked eye examination. The micronodular BCCs, which show this small nest that is separated by fibrous stroma, and the punch biopsies have a significant false negative rates to detect micronodular or mixed tumors, because I'm gonna sample just a small element of the tumor. They're very infiltrative. They have these, by definition, have to be more than 5%, this rounded, small, discrete group of cells that are less than 0.15 micrometers, nobody counts. Now, your differential will be, the main differential will be, because this is an aggressive, is this just a macronodular architecture within a nodular? In fact, that'd be a little bit difficult in partial biopsies, but if it's a micronodular within a nodular, will share the common stroma, where the micronodular would not have the common stroma and would be very infiltrated, have the satellite pattern that you see in macroloid BCC. So infiltrative, permeative growth pattern, round, small nest, very infiltrative, extending to the deep dermis and beyond. Infiltrating basal cell carcinoma has this clinically this depressed scar-like papule with by dermoscopy had this serpentine, kind of look whitish a little bit, serpentine vessels. And histology shows these compressed by collagen and fibromyxoid appearance. And very frequently they have perineural invasion, and we report that. And infiltrating basal cell can also be admixed with nodular, but the presence of the infiltrative morphology defines the tumor subtype. So essential pink papules from plaques, JAK nest, basaloid tumor cells with infiltration, desirable perineural may be present or maybe not. Sclerosing morphate basal cell carcinoma, again, this is a depressed plaque with telangiectasia. And histologically, you have this jagged tumor islands surrounded by abandoned fibrocellular stroma. And they are narrow cords, by definition, 1 to 5 cells thick and compressed by induced sclerotic collagenous stroma. And they're disrupting the normal dermal architecture. And there is, you don't see peripheral palisading or retraction artifacts. And they can be very infiltrative and penetrate deeply and into the subcutaneous tissue. And there's quite an overlap, obviously, with infiltrative BCC, but it doesn't have this infiltrative BCC, it has this induced collagenous stroma. One marker that people have explored, this is fibroblast, that didn't become very popular, is the fibroblast activation protein. The fibroblast activation protein is a type 2 membrane glycoprotein that belonging to the serine protease family, and it's found to expressed in granulation tissue of healing roots. So it has been identified as a marker of reactive tumor stroma fibroblasts, especially on peritumoral stroma fibroblasts, that they react to the invasion of the tumor cells in multiple epithelial cancers, including cutaneous malignancies. And so people have looked at this. How can we differentiate it with other sclerosing basaloid tumors, including desmoplastic trichoepithelioma or microcystic adnexocarcinoma? And they found that there's negative in desmoplastic trichoepithelioma because it doesn't actually cause this reactive fibroblast the same way that an invasive carcinoma causes. So that was in the peritumoral, they were negative, where it was actually positive in the morphic carcinoma, and there was a gradient which was more intensely positive around the tumor nest, and started losing the expression as it was going further away from the tumor nest. So people have looked at various immunohistochemical studies to see how we can differentiate sclerosing adnexal neoplasm, mainly microcystic adnexal carcinoma, desmoplastic trichoepithelioma, and the fake or infiltrated basal cell carcinoma, which is your classic differential. So MAC will be negative for BRD4, where in the contrast, more infiltrated BCC, more faithful BCC will express BRD4. And desmoplastic trichoepithelioma will be positive for BRD4, but will be positive for PH-LDA1 as well, where the BCC will be negative for PH-LDA, where MAC is going to show a mixed pattern. So that can be helpful, differentiated between the two. Another stain that people looked at it is laminin 332, which stains the basal cell carcinoma, and it actually stains quite strongly the cytoplasm, whereas in the desmoplastic trichoepithelioma, you expect this to be negative. And then microcystic adnexal carcinoma will be negative for BRD4, but positive in basal cell carcinoma. And it will be positive for laminin 332, whether the different pattern has the cytoplasm actually a linear configuration, which is kind of a little bit difficult to have in the observed. I think the observed variability here would be quite different, but it could be helpful differentiating this from in conjunction with BR4 and PH-LDA1 from these three tumors. So essential scar-like plaque ulcerated perineural invasion is commonly present. Basal squamous carcinoma is a type of BCC which has areas of both basal cell carcinoma and high-grade squamous cell carcinoma. It may be a transition zone between the two. People have contemplated if this is a truly biophenotypic carcinoma or is a collision tumor, and most recently has been shown that it is most likely a biophenotypic carcinoma, which it's a basal cell carcinoma which accumulating various genetic hits has undergone genetic transformation to a higher grade squamous cell carcinoma. And you can see the transition, the BRD4 with positive basal cell carcinoma, EMA in the negative, EMA negative, where in the squamous cell carcinoma will be BRD4 negative, EMA positive. I just want to emphasize that I don't, it's not the same. You see squamous cell differentiation all the time in basal cell carcinoma, but they look more bland. I'm not talking about this. The true basal squamous carcinoma will show high-grade squamous cell carcinoma, ugly squamous cell carcinoma. It's not, otherwise, going to call everything basal squamous carcinoma because it's so common. And perineural invasion is common to see about 5% of the cases. You have to be careful when you render this diagnosis, imply worse prognosis. Basal cell carcinoma intermixed with squamous cell carcinoma, and then desirable if you show this transition with BRD4 positivity and negativity. It is an aggressive carcinoma, has a higher rate of local recurrence than both of basal cell carcinoma and squamous cell carcinoma, and a relatively high metastatic potential. Their recurrence happens about 10 to 50% of the cases and about 4% after most. And people have looked at this, and the male gender positive margins, perineal invasion, lymphatic invasion, particular recurrence. And metastasis, once the metastatic rate is similar to actually squamous cell carcinoma, about 5 to 8% of the lymph nodes or the lung. And once it metastasizes, the prognosis is kind of in the middle between a basal cell carcinoma and a squamous cell carcinoma. Basal cell carcinoma with sarcomatoid differentiation basically have the basal cell carcinoma, and they have a component with a malignant stroma that has virus histologies, but it looks like sarcoma. It can look like a pleomorphic and differentiated sarcoma, an osteosarcoma, a chondrosarcoma, a leiomyosarcoma, or a rhabdomyosarcoma. And they kind of loses the keratin. They lose the keratin or the P63. And for some reason, most commonly, you see osteosarcoma differentiation for reasons that are not entirely clear. But this biophenotypic appearance, it is basically a transdifferentiation or a dedifferentiation. It's not a second tumor. And people have looked at this. If they're related genetically, in this nice case, you can see the undifferentiated sarcoma arising from the basal cell carcinoma, and the sarcoma metastasized to the lymph node and then metastasized to the small bowel. And people looked at this, and they share a lot of mutation, and so they have the need, and then the nidus, and then there are other mutations that tell the story of molecular progression. But as you say, all the tumors share the PTSH1, as you would expect, the basal cell carcinoma, which is very important for diagnostic purposes if you didn't have a history or you didn't have the primary tumor, and actually as well for treatment purposes, because this presumably you may use heads called inhibitors. So sensor criteria, exophytic lesions, rapid enlargement, and then you have basal cell carcinoma with a malignant mesenchymal stroma and desirable to lack epithelial markers. And then you have basal cell carcinoma with adnexal differentiation. You can have follicular differentiation, you have sebaceous differentiation, you have apocrine differentiation. Here is, for example, basal cell carcinoma with matrical differentiation. And you can see the beta-catenin stains, strong cell membrane, but you don't see the nuclear stain here at all. And infundibulocystic basal cell carcinoma, basal cell carcinoma with sebaceous differentiation. Infundibulocystic basal cell carcinoma, so this is a big tumor, infiltrated tumor, sometimes very difficult to differentiate it with basaloid follicular hamartoma. And it's interesting because you can have the hereditary infundibulocystic basal cell carcinoma syndrome that usually is associated with SUFU mutations, that they actually activate the Head-Sculpt pathway. You have CLY1 activation. And if you see, and less frequently, you can see the nevoid basal cell carcinoma syndrome. And then basal cell carcinoma with sebaceous differentiation, you can see that rarely in neurotrophic syndrome. But people have looked at this, is this real basal cell carcinoma? People have looked at this, for example, the basal cell carcinoma with multiple differentiation, and have found common mutations, including PTCH1. So really, there's strong evidence that they actually are variant of basal cell carcinoma. And usually, the predominance will be your conventional basal cell carcinoma. If you have trouble, you're not sure if it's a multiple carcinoma because you have small areas of basal cell carcinoma. Probably it's not. If it's the basal cell carcinoma with multiple differentiation, you'll see areas of classic basal cell carcinoma. But if you have conspicuous multiple differentiation, then the differential will be with multiple carcinoma. Infundibulocystic basal cell carcinoma will be sometimes difficult to differentiate with basaloid follicular hamartoma, trichoepithelioma. Sebaceous differentiation erase the possibility of sebaceous carcinoma or sebaceoma. And basal cell carcinoma with ductal differentiation, your differential diagnosis would include sweat gland carcinomas or entrapped maybe apocrine markers. So people have looked about this infundibulocystic basal cell carcinoma because sometimes some of them are basal ploid hematomas, but many of them are basal cell carcinomas. But people have questioned, were are there really basal cell carcinomas? So people have looked at this and they have documented inactivating mutations in the SUFU gene. And so the support that this is indeed a variant of basal cell carcinoma rather than just a benign neoplasm, and maybe because there are enriched in SUFU mutations, maybe there is a genetic genotype-phenotype correlation that tumors with SUFU mutations, they are more prone to get an infundibulocystic pattern rather than other patterns of basal cell carcinoma. So essential criteria and nodular skin tumors and basaloid with peripheral nuclear pulsating, and then you have different types of adnexal differentiation. Fibroepithelial basal cell carcinoma has this thin inter-anastomosing strands of basaloid cells with abundant fibroblastic stroma. Well, the controversy is some controversy if they presents a form of trichoblastoma or uncommon BCC with features of cord cyst and fibroblast-rich stroma. I think most people consider this as a subtype of basal cell carcinoma. Exophytic flask or nodule with multiple strands of basaloid epithelium. And I told you many subtypes, and really sometimes is why do we subtype? Why do we have so many subtypes? Does it really matter? Some of them, we know they're high risk. They have micronodular, infiltrating, sclerosing, morphaic, basal squamous, or basal cell carcinoma with sarcomatoid differentiation. And then you have low risk lesions like the superficial, nodular, infundibulocystic, and fibroepithelial. So people have proposed, because there is some inter-observer variability, have proposed and found that actually makes more sense because there's a better reproducibility and correlates with their clinical management is to actually group the infiltrative, sclerotic, and micronodular under one group, the infiltrative, then you have nodular, superficial, and then keep the basal squamous, infundibulocystic, sarcomatous, and fibroepithelia. I think that makes more sense. That's what I do in my practice. Never have gotten a call back from clinicians trying to subtype it even further. I don't believe in the low risk and high risk subtype because that will create some inter-observer variability there, and correlation with clinical factors necessary. So this is a proposition statement I think makes more sense, and I could totally agree with that. The new thing is you can have, since you the basal cell carcinoma have PTCH1 mutations, and then you have GLI1 activation, we have GLI1 overexpression, and there is immunohistochemical stains, but they have the background. So people have looked at the GLI1 chromogening inside of hybridization, and the basal cell carcinoma has increased more than 3 signals in more than 50% of the cases. And we can see here that the primary lung carcinoma was negative, or the collision tumor, which was a collision, or the basal squamous carcinoma will be negative. Well, the cylindroma had some, and scleroderma had some, but it was below the threshold. So you have to have a very strict validation. In this particular case, were 1 to 2 signals per cell. Well, it has to be more than 3 signals. But it was positive in benign follicular tumors. So it won't help you differentiate basal cell carcinoma with follicular benign tumors. For example, cutaneous lymphadenoma was positive. Trichoblastomas were positive, or desmoplastic trichoepithelioma were positive. So it won't be helpful on that. Basaloid follicular hamartoma, tricholimoma, and pilomatricoma, they're all positive. So it will help you differentiating a malignant basaloid neoplasm from other malignant tumors, but it will not help you differentiate basal cell carcinoma for benign follicular tumors. And people have looked at the genomic profile even further, and they have seen that in metastatic basal cell carcinoma, you have other mutations that they can activate other pathways. For example, the Hippo pathway and the PI3K-AKT pathways that can be dysregulated, and that's very important because there are potential therapeutic targets in metastatic disease. And the other thing that they found, as I mentioned previously, there is a match between the gene expression between the local recurrence and the metastasis. So that is very important because that will tell you, if you don't have the primary, that these actually are metastatic basal cell carcinoma. So they can be a very important from the diagnostic point of view, that they, if you just happen to have the local recurrence and the metastasis, that they look difficult to diagnose as metastatic carcinoma. They actually retained the mutations that the primary has, and then they have additional mutations as part of the molecular evolution of the tumor. Again, as I said, they can be positive for neuroendocrine tumors, so that can be very important to be aware of it. Sometimes they can be kind of pleomorphic, that has no significant, there's no significance in basal cell carcinomas or pleomorphic, so-called pleomorphic basal cell carcinomas, but they can stain with neuroendocrine markers. So be careful in your differential with Merkel cell carcinoma. Moving on keratoacanthomas, they are distinctive, they're self-limiting and proliferating squamous neoplasms that are characterized by rapid growth, stabilization, and spontaneous regression. And that's the definition, and it's very important to correctly diagnose to avoid overtreatments. They have a UV radiation. They are predominantly linked to UV radiation, and there is a relatively high incidence of previous skin cancer or precancer. And most lesions develop in a reaction to something. Practically any insult. It could be electromagnetic radiation, it could be chemical factors, it could be drugs, foreign bodies, etc., infections, chemical carcinogens. So this seems like there's a UV platform, UV related pathway background, and then you have an insult, and you get these tumors that they look very characteristic. They have this relatively symmetrical exoendophytic lesion with this central keratin field crater, and then they have this compact orthokeratosis of tricholimal type with this glassy eosinophilic cytoplasm and then neutrophilic abscesses. The peripheral cells, they don't look atypical. They have a normal nuclear to cytoplasmic ratio. And this, they can look more, they can have this infundibulocystic type structures resembling a cyst. But if you go a little bit the periphery, they have this glassy cytoplasm with normal NC ratio and not significant celluloid atypia, no hyperchromatic crowded nucleoli. And while they're regressing, they can actually even resemble a cyst or a comedone. So keratocanthomas is a self-limiting squamoproliferative lesion on sun-damaged skin that can be diagnosed on morphology, clinical, and it's different from squamous cell carcinoma by genetics and clinical outcomes. There are two distinct biologic entities, and it seems when we give BRAF inhibitors, we get a lot of these K lesions. So it seems they're related to activation of the MAPK pathway like you see when you get this BRAF inhibitors. And it seems that external trauma or inflammation, they can actually, in the UV sun damaged skin, can activate the MAPK pathway and develop to keratoacanthomas. But this can regress, which is very important, so we can avoid over-treating these patients. So there's a burden of the genetic, epigenetic, and malignant phenotype biomarker expression is low in relation to conventional squamous cell carcinoma. They share some driver mutations. It's interesting that the mutations on tumor suppression genes are actually low in keratoacanthomas. And so when you have an abnormal p53, diffusion null or irregular KI beyond the periphery, that would support a cutaneous squamous cell carcinoma rather than a KA. For example, this null phenotype here, there's no p53 expression, or Ki63 that is beyond just the basal layer. It's actually compatible with the conventional squamous cell carcinoma rather than a KA, where in KA you see this peripheral p53 pattern, which is congruent with the peripheral pattern of Ki67, as you see in keratoacanthomas. There are many different types of keratoacanthomas: giant keratoacanthomas, keratoacanthomas centrifugum marginatum, which is only affecting the limbs and may be associated with significant scarring. You have multiple keratoacanthoma-like proliferations and eruptive squamous atypia, which is probably a mixed bag. It's probably KAs, KA-like, pseudoepitheliomatous hyperplasia, etc. You have keratoacanthomas in Muir-Torres syndrome, usually early in young individuals associated with sebaceous differentiation. Then you have multiple self-healing epitheliomas of Ferguson and Smith, which is an autosomal dominant inherited condition with variable penetrance, and it has a follicular K-like lesions. The palms and soles are never affected, and they lack the capacity to metastasize, and then generalized eruptive keratoacanthoma of Grybowski. They are usually non-familial. They can be hundreds and thousands, dome-shaped follicular papules, but they don't usually leave scar. And the importance of this is recognized so that you don't overtreat patients. Of course, there is a percentage you can have conventional cases. That's why we want to see the whole thing rather than just a transected lesions, or most of the lesion at least. It can happen. It's a well-known phenomenon. In a series of 3,000 cases, have about 5%, and it actually increased quite significantly in older individuals, more than 80 or 90 years old. And squamous cell carcinoma, invasive squamous cell carcinoma. The first one is verrucous squamous cell carcinoma, which has this characteristic undulant architecture. It happens in the skin and oral cavity, the so-called Ackermann tumor, the old Ackermann, not the dermatologist. The cutaneous lesions are common in palms, soles, and distal gizzards. You can see it in anogenital region. It's called Buschke-Lowenstein tumor. As I said, you can see it in the skin, but it's more rare. It usually it's not associated with HPV. Most of the times, there's a chronic irritation, inflammation, impaired immunity has been proposed as possible etiologic factors, and also can be associated with chronic ulcers and scar. And people have looked at this since that these are HPV negative. You're not going to see colocytes, but still warrants further investigation. And this is a characteristic of minimal atypia that has this papillomatous configuration, and the bottom, the base is smooth and kind of pushes. Doesn't have an infiltrating border. It has minimal cytologic atypia, and the interspersed, the interradius spaces are greatly diminished with a great reduced vascularity. A lot of things can mimic a verrucous squamous cell carcinoma. You have to be careful. So infectious diseases, fungal, mycobacterial, leishmaniasis can all kind of actually mimic significantly. In the penis, for example, verrucous sarcoma, you want to mention, diagnose verrucous carcinoma in the penis, and was very totally benign verrucous sarcoma. That would be a terrible and, of course, a medical legal case. So deeply endophytic, club-shaped tongues with pushing borders of well-differentiated squamous cell carcinoma is really one you want to see that raise suspicion for verrucous carcinoma. Sometimes squamous cell carcinomas can have acantholytic features that there are impaired intercellular adhesion that may result in the form of pseudoglandular spaces. And invasive squamous cell carcinoma, if it gets too acantholytic and has a pseudoglandular or can resemble potentially vascular tumor, and the cells separated, but they still look atypical. They're going to be positive for EMA or CA. They're pseudoglandular, but it's just acantholysis. But other than that, it's a conventional squamous cell carcinoma, which you don't want to see this acantholysis of various sizes and spaces. The old days, I thought it was more aggressive. Then there was conflicts, but I think people have looked at it and have done multivariate analysis, and there's no significant differences between acantholytic and non-acantholytic squamous cell carcinoma. So the notion that acantholytic squamous cell carcinoma is more aggressive is just not substantiated by the data. Lymphoepithelial carcinoma is a poorly differentiated squamous cell carcinoma, has this variable admixture of lymphoplasmacytic infiltrate obscuring the true neoplastic cells. But if you go hyper, you see this solitary single, very atypical neoplastic cells that are staying obviously with cytokeratin. It's not related to EBV. People have looked at this. It's not an EBV. It's just obscured by lymphoplasmacytic inflammation. So a poorly differentiated squamous cell carcinoma with tumor islands surrounded and infiltrated by lymphocytes and variable number of plasma cells. It can have clear cells. It can be diffusely clear cells. These are glycogen, so it's pH positive, diastase sensitive. Sometimes it can have the signaling appearance with unilocular vacuoles, but other than that, it's a conventional squamous cell carcinoma. It just have this peculiar vacuolization. People have looked at this. This is a tricholemma carcinoma. Tricholemma carcinoma is different. Usually it's deeper. It has no connection to the epidermis, and they may show peripheral palisading and increased basement membrane prominence and pilar hyalinization. Clear cell basal cell carcinoma will be BRAP4 positive. The presence of ducts, that are highlighted by EMA, will actually raise the possibility of porocarcinoma or hydranal carcinoma or dermal duct tumor. Clear cell atypical fibrosarcoma, we'll talk about this. It looks very, very ugly. And of course, balloon cell melanoma will be your differential, or a metastatic clear cell tumor, such as a renal cell tumor, will be positive for PAX8. And clear cell atypical fibrosarcoma will be very ugly, and it will not stain, the keratins will not stain for anything by definition. So, as you see with clear cell differentiation, at least 25% of cases. Spindle cell squamous cell carcinoma, it looks very spindle, poorly differentiated type. You may see a more conventional keratinizing squamous cell carcinoma, you may not. It has this fascicle of pleomorphic cells with frequent mitotic activity. It looks very ugly, resembling a sarcoma, but it stains for keratins and P63. Similar tumors, you see that in the head and neck, laryngeal, hypopharyngeal, etc. And people have looked if they are related, and they show a monoclonal origin. So it's basically is a conventional squamous cell carcinoma with additional genetic seeds. The additional genetic seeds has this epithelial mesenchymal transition to more spindle cells, but they're not truly transformed to a bona fide sarcoma. That's why they're staying with keratins and P63. And your differential obviously will include all this, and we'll talk about this. We'll talk about this differential. A typical fibrosarcoma will not stain for keratins. The same thing for superficial undifferentiated pleomorphic sarcoma. Melanoma will stain for melanocytic markers, liposarcoma with SMA and desmin, and in the form of lymphoma markers. But there's a lot of it's kind of trendy now to look about undifferentiated, undifferentiated melanoma, which undiagnosed, less underdiagnosed, I'm sorry, because it's almost impossible to diagnose it without molecular, unless you see a background good conventional melanoma. And here is PRAME. People have looked, so PRAME can be actually helpful. Not all the times. This was positive, but in the dedifferentiated component was actually positive, which can be positive in the dedifferentiated melanoma. Of course, we have to be careful, and people have looked at PRAME expression of spindle cell melanoma, MPNST, etc. You have to be careful. It was statistically significant in relation to sarcoma ACC, but it's not perfect. Certainly, there are sarcomatoid squamous cell carcinoma that stain for PRAME, and melanomas that don't stain. So it's another marker that it's an armamentarium and be helpful in conjunction with other histochemical markers and molecular as part of the panel. So just to be aware, we use it, but we have to be careful. And the sensor criteria: closely packed fascicles with pleomorphic spindle cells with frequent mitotic activity. And it is a predictor of poor prognosis. It's an ugly, aggressive tumor. The depth of invasion into bone or muscle, as well as origination from a burn site or radiation damage, are aggressive factors that imply a worse outcome. Penile variants are especially aggressive with a high rate of metastasis. Squamous cell carcinoma with sarcoma differentiation is different. They are transdifferentiated to a bona fide sarcoma. They can express osteosarcoma, chondrosarcoma, rhabdomyosarcoma. They lose their epithelial markers. They lose their developed stain for P63. It has transdifferentiated to a sarcoma. And there are clonally related. People have looked at this. They are basically squamous cell carcinoma. They're clonally related to a squamous cell carcinoma with additional genetic hits, has transdifferentiated to a bona fide sarcoma. And desirable, recognized SSC with recognizable sarcoma differentiation with different lineages, chondroblastic, osteoblastic, etc. So this was the lecture. This is my email if you want to email me. You can follow me on Twitter. I put a lot of things related to my field. And I have a channel that I'm presumably you're watching from this channel. But you can subscribe so you can get notifications. I put all my lectures there. And I hope you find this lecture helpful. And if you like it, please let me know. And I will try to put additional lectures in the channel. And thank you very much.